So welcome everyone, and thank you for joining us for today's webinar. My name is Stephanie Ince. I'm the Executive Director at the Dystonia Medical Research Foundation Canada, which is a national charitable organization whose mission is to support the needs of dystonia patients and their families in Canada. Today we're presenting the first webinar in the Living Well webinar series designed to help you live well with dystonia. And our first topic is Dystonia and Sleep. Today, we're very lucky to be joined by Dr. Davide Martino, MD, PhD, and Director of the Movement Disorders Program, Cummings School of Medicine at the University of Calgary. Dr. Martino has been the Director of the Movement Disorders Program and Associate Professor, Department of Clinical Neurosciences and Radiology at the University of Calgary. He's a movement disorder clinical researcher with experience in collaborative multidisciplinary research encompassing neurostimulation, brain imaging, neuropsychiatry, and epidemiology. He has specific training and expertise in non-invasive brain stimulation and epidemiology focused on network disorders, primarily dystonia, Tourette syndrome, and Parkinson's disease. The overarching goal of Dr. Martino's research program in idiopathic dystonia is to identify biomarkers of progression of dystonia over time using neuropsychological, MRI-based, and genetic markers, and to explore their role as predictors of response to treatments. Dr. Martino has been a wonderful supporter of the dystonia community and a friend of the DMRF Canada, and we're very happy to have him with us today. So just a little bit of housekeeping before we get started. First, a very important reminder that this is a webinar presentation that aims to provide patients and caregivers with tips and tools for how to live your best life with dystonia, but we urge you and remind you to speak with your own medical doctor or movement disorder specialist for full and complete details, and to remember that you are in control of your own health. A reminder that today's presentation will be made available and emailed to all of you once it's available online. In terms of questions, as you know, we did collect your thoughts in advance of this session, and we've already shared those with Dr. Martino to help him with the development of his presentation. But as well, a reminder that there will be lots of time for Dr. Martino to answer any questions that come up during the presentations. I will be monitoring these questions within the Q&A section. So feel free to type your questions into the Q&A section as they occur to you. And I will be bringing those to Dr. Martino's attention at the appropriate time at the end of his presentation. Also, just a reminder that there is a chat function, so feel free to use the chat function to introduce yourselves to others who may have joined, but just a reminder that I will not be monitoring that chat box for questions. So without further ado, I will turn things over to Dr. Martino.
Well, thank you, Stephanie. Good afternoon. Can you hear me well? Yes. Just interrupt me if you can't hear me very well. And it's a real pleasure to be holding this webinar, and I'm really grateful to DMRF Canada for all its work, which is precious and invaluable, and for inviting me, and all of you for attending this webinar, which, as Stephanie has mentioned, and as you can see in the slide, is going to focus on the relationship and the connection between dystonia and sleep, if there is. Of course, the question is rather rhetorical, because otherwise we wouldn't be holding this webinar. And but most importantly, is the question is the key question is how well do we understand it, and what we need to do to improve our understanding of it. So, yeah, this is what I'm going to be talking about. It's primarily, after a little preamble on what impacts quality of life and disability in dystonia, I'm going to illustrate a little bit what, as this is highly relevant to what we're going to be talking about, the physiology of sleep, and what are the objective and subjective methods that we have to screen and record it. Then I'm going to give you a little summary of what is known from the scientific literature on the sleep disruption problems in dystonia. And then we're going to try and answer the question of why do people with dystonia have sleep abnormalities, to conclude in order to, with some considerations in order to move forward with management, and illustrate why we think that it's time for a new model of care in dystonia, also with respect to sleep. So as this is just a preamble to introduce to the problem of disability in people with dystonia. And I'm going to focus primarily on what we call idiopathic dystonia. So dystonia that is not really caused by a very specific genetic cause or a neurodegenerative process or a brain lesion or cerebral palsy. And I'm going to, obviously, most of the considerations and the research on sleep are coming from adult onset dystonia. But in general, the causes for disability in dystonia are highly diverse, and it's not just physical or motor functioning or the severity of motor symptoms in dystonia that cause disability. And this is also shown by the fact that despite motor improvements with botulinum toxin, many patients still experience difficulties in performing daily life activities. And amongst the largest contributors to disability that we are aware of, for example, we find depression, anxiety, and pain, which are obviously non-motor features in people with dystonia. And this is coming mostly from data on cervical dystonia. So this is a little study that we did in the past 24 months from the Calgary population that supports this concept, showing that the severity of dystonia is really affecting only one specific aspect of quality of life, which is the activities of daily living, whereas other features, and particularly the depression feature, has a predictive effect on pretty much all the main domains of quality of life. So apart from activities of daily living, also the social stigma and even emotional well-being, social and family life, and pain. We don't really know exactly the extent of sleep impairment with respect to quality of life impairment, but we will comment on this in greater depth. So, as I said, I would like to take you on a little overview, walk you through a little overview on the physiology of sleep, because it's necessary to understand what the relationship between sleep and dystonia. So each night, we really take a roller coaster ride through different phases of sleep. And we are unaware of what goes on while we sleep, but our brain and body are in an active state, and each stage of sleep has distinct qualities that help restoration, and how we move through each phase of sleep plays a large role in our body's status the following day. So during an ideal night's sleep, we go through several cycles that last, each of which lasts about 90 minutes. And each cycle plays a role in maintaining our mental and physical health. And but the amount of each phase of sleep can vary substantially between nights and across different people. So traditionally, we categorize sleep in two different main categories. We have non-REM sleep or REM sleep. REM stands for, as most of you will know, rapid eye movement. And this is exactly what it is. If we have our eyes remaining still during sleep, then we are in non-REM sleep. If they move rapidly under our eyelids, we are in REM sleep. And together, these two categories of sleep make up a single cycle through which our brain is progressing sequentially from wakefulness to light sleep, deep sleep, and REM sleep. So we start from awake time, which is the time that we spend in bed before and immediately after falling asleep, or at the time of falling asleep. It includes also some awake time during the night, is also including brief awakenings during the night, which are completely normal for healthy adults. And then we move on to the actual light sleep, which initiates our sleep cycle. And it's what we call the non-REM 2. And this really acts as a transition to deeper sleep. During this phase, our muscles begin to relax, our heart rate and breathing slow down, and we wake up easily. And we can also see that a muscle may jerk inadvertently, which is completely normal in this phase. Our respiration slows down, our body temperature drops, our heart rate goes down, and initial patterns of sleep activity appear on brain waves. And then we move to deep sleep, which is the stage 3, which is really the most restorating and rejuvenating phase of our sleep. It really focuses on the body more than the brain. The brain is pretty switched off, and the activity in the brain is comprised of very slow waves, but there is increased blood flow to the muscles and to the rest of the body. And this is where, for example, muscle grow, and growth hormone is released. And this is a particularly relevant type of restorative and growth-related sleep in young people. It also helps the brain to relax and its activity and get rid of all the toxic metabolites that can affect its function. Then we move into this very evolutionarily new form of sleep, which is REM sleep, that is a paradoxical sleep, because if we look at record the brain activity during REM sleep, we can notice that the brain is actually similar to an awake brain. It's very active. And this is the type of deep sleep that focuses on the brain. The brain is active. We have dreams. We have learning processes and memory consolidations from the previous days. At the same time, the body is switched off, and muscles, which were relaxed before, become completely immobile in a healthy, normal REM sleep. This is why we don't act out our dreams at night. Our eye move, the only muscles that work are the eye ones, and that's why we have eye movement in REM sleep. There's also some other activities like blood flow, increase the genitals, for example. This is why men have erections during REM sleep. But it's a very useful and restorative type of sleep as well. So interestingly, in the first part of the night, we have non-REM sleep much more than REM sleep. And this is important because we can rest. If we only have a few hours of sleep, at least we guarantee our brain the good restoration coming from non-REM sleep. And REM sleep becomes the prevalent type of sleep in the second part of the night, closer to our morning time. This is why we remember more vividly our dreams when we wake up in the second part of the night or in the morning. So another important thing about REM sleep is that, in particular, is that it tends to decrease with age. So REM sleep is particularly active in the first part of our life, and then it gradually goes down. We need it less overall with aging. So since all this is happening during sleep, it is not surprising that in order to record sleep, we really have to we can't just record our brain waves with an EEG. We really need something more complex. And this is what the polysomnography recording is about, which is done obviously in hospital. And in this period of time, we place sensors on the scalp to record the EEG and brainwave activity, but at the same time, we can record from the muscles, across different muscles in the body. We can record the eye movements, and also we have a sensor at the nose to measure airflow. We have elastic belt sensors that around the chest and the belly that measure the amount of effort to breathe. We have sensors to measure the amount of oxygen in the blood that tells us how well we are breathing. And all this is being recorded while at the same time there may be even a video camera that records the individual that is sleeping, so that the behavior of the individual is coupled to what is being recorded by all these different tracks. So having said this, do people with dystonia have sleep problems, and as a specific patient group? Now, there have been only a few studies that have been conducted in people with adult onset idiopathic dystonia, and particularly cranial dystonia like blepharospasm or oromandibular dystonia or cervical dystonia, that have used polysomnography to study sleep. And even though these studies really may not necessarily tell a story that can be generalized across the whole population of people with dystonia, they show that about half of the people with dystonia have some disruption of sleep. And interestingly, the majority of these studies have been conducted in Europe or then in Eastern Asia, proportionately much less for some reason in North America. But overall, the quality of night sleep is decreased in people with dystonia as a group, which doesn't mean that all patients present sleep problems, obviously. This decrease in quality of sleep is reflected by an increased latency of sleep, so more time to fall asleep, a decreased sleep efficiency with more awakenings during the night, and less REM sleep. Overall, there is a problem, therefore, of architecture of sleep. Importantly, the most sophisticated sleep study that has ever been conducted in people with dystonia was conducted in Italy at the University of Bologna, as this study by Antelmi, which is a huge sleep center, and has reliably demonstrated that dystonia does not persist in sleep, which is another very important point to remember which we'll mention later when we will talk about the possible reasons for which sleep is disrupted in dystonia. We don't really have dystonic movements or postures during sleep. So sleep and excessive daytime sleepiness can also be investigated in a slightly cheaper and easier way through questionnaires, self-reported questionnaires. We have two important questionnaires that we can use. One is called the Pittsburgh Sleep Quality Inventory that looks at sleep quality at night, and the other one is the Epworth Sleepiness Scale that looks at daytime sleepiness. And the number of studies that have looked at sleep in people with dystonia using these questionnaires is much higher than the number of studies that use the objective polysomnography sleep studies. But these questionnaires are also, as you can imagine, somewhat less informative on the structure of sleep. In any case, there is an interesting correspondence between how many people are impaired on sleep quality on questionnaires and how many are impaired with sleep studies. They're pretty much between 40 and 70%. Also, what the subjective scales allow capturing is a broader picture on the quality of sleep across a longer period of time, because with polysomnography, we really can only record what is happening during the night or the nights of the recording. And this also, using questionnaires, also allows us to correlate sleep quality to other features of patients with dystonia. For example, using self-reported sleep has allowed us to determine that poor sleep quality is actually significantly influenced by concurrent depression, but not so much by the severity of the motor features of dystonia, of dystonic postures or dystonic movement or tremor. Also, these scales have allowed us to observe how poor quality of sleep may worsen quality of life in dystonia, which is kind of an obvious finding, really, to which we will come back. Interestingly, also, as a group, dystonia patients do not commonly complain of excessive daytime sleepiness, despite the decreased quality of night sleep. This is, again, not true for everybody, but it's also kind of an interesting finding that we need to discuss in greater depth. There may also be an association which deserves more investigation, between dystonia and another condition called restless leg syndrome. Restless legs is characterized by very uncomfortable sensations that are mostly located at the legs, often described as an unbearable tension, sometimes itch-like, that is alleviated with movement, and is rather common, and in a substantial proportion of patients is caused by iron deficiency. Now, between 15 and 20% of patients with cervical dystonia or blepharospasm may complain of symptoms that resemble restless leg syndrome. Another interesting finding from these studies is that, as a whole, sleep quality was not particularly improved by Botox, despite Botox improves motor features, as we know. Now, I've seen how many attendees actually report the opposite. Many attendees to this webinar have said the opposite. This is something that I'd like to elaborate a little bit more also later or during the Q&A session. Sleep-related problems, as I said, affect quality of life. And again, this is not surprising. We also said that people with dystonia do not have a great deal of excessive daytime sleepiness. But there are data, like the one that I'm showing in this slide, that show that excessive daytime sleepiness, more than insomnia, more than interruptions at night, sleep interruptions at night, when present, excessive daytime sleepiness may predict the vitality and the mental health domains of quality of life in people with dystonia. And again, this is not really surprising if we think about it, because poor sleep really impacts mostly our quality of life when it generates problems when we are most active, which is during the day. So predictably, the people with dystonia who are most impacted by poor sleep are also those who feel sleepier during the day. And they also feel sleepier, but they may also feel more anxious, and they feel also more fatigued during the day. And so quality of life is clearly impacted. This research also shows that sleep-related problems, again, do not correlate so much with the motor symptoms of dystonia, but they are linked more to depression, to pain, to anxiety in people with dystonia. What about, this is mostly seen in people with adult onset focal dystonia. What about generalized dystonia, which really we typically mean by this early onset dystonia, the idiopathic cases, not caused by cerebral palsy or by other degenerative causes of dystonia. These earlier studies showed that light sleep in people with generalized dystonia may be affected, as it's reflected by an abnormally large presence of these sleep spindles that characterize the light sleep, the non-REM stage 2, which we typically see once we transition from the initial phase to that of proper light sleep. Well, now we suspect that those earlier studies were confounded by the fact that most of these patients were on medications, particularly on benzodiazepines, which may affect sleep considerably, and we'll come back to this later. Another similar finding that could be the result of medications in these people, these younger people with generalized dystonia, is that their REM sleep was also more suppressed, which is a problem, particularly in young kids or in adolescents. But overall, these young people with dystonia have shown a problem in sleep continuity, which again is not caused by the presence of dystonia during sleep, because dystonia disappears during sleep. So these patients tend to drift more often towards a lighter sleep than a deeper sleep, and this may have an impact on their quality and even on their growth overall. In very young people, another very important situation or condition is called status dystonicus, which you probably have heard of, or dystonic storm. This is typical of people with generalized dystonia, often triggered by infection. These are people with generalized dystonias that are caused by genetic condition or neurodegenerative condition or a metabolic condition. And their dystonia may, in periods of time, become very severe and develop into a dystonic storm, in which the active muscle contraction is very sustained and may even lead to exhaustion and to muscle breakdown, which may lead to kidney failure if it's not treated properly. This is why some of these patients, in this status, they may need an admission to intensive care unit. Now, the reason I'm mentioning this here is that one of the first signs that a young patient with generalized dystonia is drifting towards status dystonicus is that their sleep pattern goes awry, becomes abnormal. And so it's very important in these patients with generalized dystonia in the first 2 decades of life, particularly, to monitor their sleep and make sure that it's not changing and they're not sleeping less or having a very interrupted nighttime sleep. And one way to help this and even prevent the development of status dystonicus in these patients, to restore sleep. And in doing this, we can try using melatonin, which is probably the best option in these scenarios, because melatonin acts as a chronobiotic. In other words, it tunes in our wakefulness-sleep cycle to the light-darkness cycle outside, allowing sleep to be more consistent and reliable. It can also be used as a sleep inductor, and it can also be used across all ages, but usually it's used at different doses according to age, obviously, but it's usually used for not more than 12 weeks of time, because melatonin is produced by our brain, and we don't want to provide only an external supply of melatonin, which will suppress the proper brain ability to produce melatonin in the future. So it's really for short courses, but can be very helpful. Just to target another category of patients with dystonia and sleep, it's the dopa-responsive patients. These are, as you know, very specific groups of people with dystonia who have a specific enzyme deficiency, and they don't produce dopamine, so they need levodopa to restore this. And in fact, they get much, much better when they take levodopa. It's almost a cure for these patients. Now, these patients typically, what is the relationship of sleep to these patients? That their symptoms worsen over the course of the day, and they improve markedly after sleep. So they have a sleep benefit. And interestingly, some of them have what we call REM sleep behavior disorder. So when they are in REM sleep, and as I mentioned earlier, REM sleep is when our muscles are completely switched off. We dream, but we can't act out our dreams. These patients may have actually some muscle activity during REM sleep, which leads to the production of abnormal behaviors that looks like dream enactment. Now, interestingly, this is also seen, it's one of the very, very early signs of Parkinson's disease. This doesn't mean that dopa-responsive dystonia leads to Parkinson's disease. At least this is not something that has been demonstrated, but it's an interesting point that links together dopamine and REM sleep. And this brings me to the very important question of why should sleep be disturbed in dystonia? What is causing these sleep disruptions in people with dystonia? Now, there isn't a single answer to this question, so we're going to just review together possible answers, because they also offer some indications on possible strategies on how to move forward with management. The first hypothesis is that dystonia, in the sense of abnormal muscle contractions and sleep disruption, they all come from the same brain dysfunction. And this is an interesting hypothesis because sleep problems occur in many different types of movement disorders, for example, in Parkinson's disease, or in some inflammations of the brain that involve the brain networks that are involved in movement disorders, the basal ganglia and related structures, which select and facilitate the execution and the suppression of movement. Now, if this is the case, then many different neurotransmitters can be involved, although 3 are the most relevant ones, because they are critical for the regulation of movement output, but also of motivation, of the regulation of our emotions, some cognitive functions that are crucial for learning or behavior, like working memory. These neurotransmitters are dopamine, serotonin, and norepinephrine. And interestingly, we know that dopamine is highly related to the abnormal movements that we see in dystonia. As I said, some forms of dystonia are caused by a total deficiency of dopamine that is improved by levodopa. And dystonia can be a side effect of medications like antipsychotics that block dopamine receptors. So dopamine is important also in controlling our level of alertness. So dopamine may be involved in the frequent awakenings that some patients with dystonia report when they sleep at night. Serotonin, on the other hand, is the neurotransmitter of emotions, emotion regulation. It's highly linked to anxiety, and therefore may be involved indirectly in the difficulty of falling asleep at night, also known as early insomnia. This is why some patients with dystonia may sleep better at night if they take a small amount of a medication called mirtazapine, which is an antidepressant that controls both serotonin and norepinephrine transmission. Another neurotransmitter system that is not on this slide but might relieve pre-sleep anxiety is the cannabinoid system. Although there's virtually no evidence at all yet that cannabis compounds can really improve sleep in dystonia. And we definitely need appropriate clinical trials to confirm this. So as I said, it's unlikely that there is only one explanation for sleep disruption in dystonia. There may be several factors involved, and we must take them all into account. One which I will never stress enough is the use of some medications that can affect sleep. In particular, benzodiazepines. Again, the most commonly used are clonazepam, lorazepam, diazepam. There are others. And there are also others that are benzodiazepine-like, for example, zopiclone. Now, all these medications are established short-term treatment for insomnia. And I underline short-term because these drugs are not advised for chronic use, despite a lot of patients take them chronically. In this study here in the slide, coming from the International Dystonia Coalition database, shows that around the world, more than one third of patients with adult onset dystonia take benzodiazepines regularly, and others use sleep-inducing medications like zopiclone. And interestingly, these patients are more likely to be those patients who also have anxiety and depression. And as I mentioned before, benzodiazepine suppresses slow wave or deep sleep, which is the one that allows the brain and the body to get rid of toxic substances and restore a good level of reactivity for the following day, and consolidate also our memory and what we have learned the day before. So even if they help falling asleep faster, benzodiazepines come with a cost, which is usually morning sleepiness, sedation, because they impair sleep. They're also highly addictive. They force often to increase the dose necessary to obtain the same effect. So when we discontinue them too quickly, this may cause a rebound of insomnia, which ultimately contributes even further to reducing sleep quality in some patients. Most antidepressants, including SSRIs like fluoxetine, fluvoxamine, escitalopram, citalopram, all these names will be familiar to some of you, are known to suppress REM sleep to some extent. So in some patients with dystonia, they can somewhat disturb the continuity of sleep. However, they're not nearly as damaging for sleep quality as benzodiazepines. So if they need to be used to treat a mood dysregulation, mood problems, or anxiety, they can and should be used, just with some closer monitoring of sleep quality. So it cannot be excluded, therefore, that reduced sleep quality occurs in dystonia as a side effect of medications in some patients. A third hypothesis is that sleep disturbance is caused by dystonic movement and associated pain. However, in this context, I want to keep the impact of these two things, abnormal movements and pain, separate, because probably they have a different impact on sleep. First, the severity of dystonia, as we have said already, was not correlated with the quality of sleep in different studies. And one other study has also reported that sleep quality usually does not improve after botulinum toxin treatment, despite this treatment may improve motor symptoms. I know that this may not be true for everybody, that some patients with dystonia sleep better if the muscle contractions that they have, particularly in cervical dystonia, are improved by the botulinum toxin treatment. But we have to keep in mind that in the majority of patients, lying down in bed and relaxing improves dystonia anyway. So overall, it's not very likely that motor symptoms are key players in the sleep disruption in dystonia. A different consideration should be made around pain and sensory discomfort, like the one that we see in restless leg syndrome, for example. When patients have pain, especially in their neck and in their upper spine, and this is not relieved by lying supine in bed, there's no doubt that we can have early insomnia. And in these cases, optimizing pain management is crucial. But we need more studies that teach us what pain management has the best spin-off effect on sleep. We don't really know that yet. For this, we need a better way also to measure pain in people with dystonia, which is a project that we are conducting here in Calgary with the collaboration of a panel of experts from North America and Europe. And a fourth hypothesis is that psychological distress is a mediator of sleep disturbance, which obviously makes sense. And I really want to stress how all these factors may be important contributors. And again, that there isn't a single answer to why sleep is perturbed in dystonia. Another question that still needs to be addressed in full is whether specific factors contribute to specific types of sleep disruption. And we touched upon this vis-a-vis medications and chemical imbalance before, but we still don't know yet this very well. So depression and anxiety. A recent study measuring health-related quality of life in people with cervical dystonia showed that almost half of them report feeling depressed, annoyed, or bitter. A third of them felt lonely or isolated, and 3/4 reported feeling uneasy in public, probably due to the visible symptoms of dystonia. We know that at least 2 studies have shown that the poor quality of sleep measured through the questionnaires was correlated with the severity of depression in people with focal dystonia. This is also why I always stress the need to manage actively depression and anxiety symptoms in dystonia. And also that we shouldn't be afraid of using antidepressants alongside appropriate counseling or cognitive behavioral therapy, and try to stay away as much as possible from benzodiazepines, especially as long-term remedies. What does deep brain stimulation do on sleep in dystonia? There's not really much out there. There's just really this very recently published study that looked into this. And this is an unusual study because it's a study on cranial dystonia, people with blepharospasm or oromandibular dystonia, with or without cervical dystonia. It's called MAGE syndrome. It's one of the most common forms of adult onset dystonias. And these patients were treated with deep brain stimulation, which is unusual in the West, is more common in the Far East of Asia, in China and Japan, because these patients do quite well on botulinum toxins, so they don't really need surgery. But what this study found was that there was a positive and sustained effect of this intervention on the quality of sleep. And this was using a target that is not the most used target for DBS in dystonia. The most common is the GPI, and they used the subthalamic nucleus, the STN, which is the second target for dystonia, which is becoming more and more used, but is the first target in Parkinson's disease. There's a possibility that changing the activity of this particular brain region, which influences the regulation of sleep, wakefulness, sleep can also improve, but there's very little on this to date. So overall, this is just some practice points to remember. Research is suggesting a prevalence of impaired sleep quality between 40 and 70% of patients with focal cranial, but also cervical dystonia. An impaired quality of life in people with dystonia might, at least in part, be mediated by other non-motor symptoms. There's not so much of an excessive daytime sleepiness problem in people with dystonia. Patients with dystonia should routinely be assessed for sleep disturbance, either using validated sleep questionnaires like the Pittsburgh or polysomnography. the occurrence of sleep disturbances as a side effect of medication should be carefully monitored in people with dystonia. There's also some preliminary research results that suggest that botulinum toxin is not effective in improving sleep in cervical dystonia. Short-term treatment with benzodiazepines and cognitive behavioral therapy for insomnia are effective treatments for patients with insomnia in general, but have not yet been investigated in patients with dystonia, and we should be aware of monitoring very closely the short-term use of benzodiazepines. Since patients with dystonia may already be on other sedating medications, like even baclofen or other medications or anticholinergics, caution is needed before adding sleep-inducing medication for insomnia. Screening dystonia patients for non-motor symptoms is still an unmet need. This is not really happening, as you know, in routine clinical practice. And patients are aware and complain about this. As we know, the good response to botulinum toxin in the majority of patients with dystonia forces movement disorders clinics to offer visits every 3 months to repeat this treatment. But the cost of this is the appointments are kept brief. I call this the Botox curse. This aspect, which coupled to an underestimation of non-motor issues in people with dystonia by healthcare professionals, leads to pretty much neglect of these problems, which even patients do not necessarily relate to dystonia, and they try to address with other health professionals, such as family physicians, but very patchily. So having the opportunity to screen for these problems efficiently is very important. We devised this questionnaire that we published with a group of European colleagues last year as just one, as a first attempt to achieve this. This is a questionnaire that could definitely be improved, but it's swift enough and consists of 14 yes/no questions that tap on different non-motor issues, including sleep, as you can see from the first 2 questions. And this is along the lines of a very similar tool that has been developed earlier for Parkinson's disease. What about behavioral interventions in dystonia? Well, they are markedly under-investigated for the same reasons that I just mentioned. Non-motor symptoms are under-ascertained, under-treated actively by movement disorders specialists in people with dystonia. So most of these behavioral interventions have focused on anxiety and social anxiety in particular, and depression. But what has been observed so far is that these interventions, especially those that are focused on anxiety management and optimization of coping strategies, are well accepted by patients who tend to improve their quality of life when they have them. However, the studies that have been done on these interventions are quite low quality overall, and we really need to define which approach is the most efficient in people with dystonia. And also, sleep outcomes, as I mentioned here, have never really been investigated in behavioral treatments. So, although it is logical to predict that these type of treatments can help the quality of sleep, we don't really know for sure, and particularly we ignore which specific treatment would help the most. What we can say is that approaches based on relaxation are probably the most efficient, including those that are based on mindfulness practices, for example, and should probably be investigated more systematically. What about complementary and alternative medicine approaches? These are defined as a group of diverse medical and healthcare systems, practices, and products that are not generally considered part of conventional medicine. And they can also be at times integrated with conventional medicine and what we call integrative medicine. But the boundaries that separate conventional from complementary and alternative medicine are not always clear. I like to quote this study because this is really still the most updated, although it's about 8 years old, snapshot on the actual use and the related efficacy and quality of life for this highly diverse group of interventions. The exercise category is broad and includes modalities such as yoga, distance running, aerobics, strength training. Now, this is coming from the US, and despite this lack of evidence, even in the US, health insurance companies are now including some of these modalities as covered treatments. But there's also a need to study these approaches better, and also a need for national standards for certification of CAM practitioners and for what qualifies as a specific complementary and alternative medicine therapy. Overall, there is really no reason to believe that general sleep hygiene measures should not apply to patients with dystonia as well. I mean, they do apply. One important aspect for sleep hygiene that is true across the whole general population, including dystonia people, is to minimize screen time, especially smartphones and computer screens, more than television screens, and abolish this use in the 2-3 hours prior to bedtime. This is extremely important to prevent early insomnia and guarantee a sufficient percentage of deep, restorative non-REM sleep, which is probably already compromised a bit in people with dystonia. Also, a good regime of physical exercise helps relaxation at the end of the day. So although it is not advisable very close to bedtime, as it might prolong the time needed to fall asleep, it is definitely an advisable part of our lifestyle. So research should really focus in the future on doing more polysomnography studies and do more rigorous studies in drug-free people with dystonia to really understand the baseline sleep disruption in people with dystonia. We should also investigate it more in other forms of dystonia other than cranial and cervical, but also more in hand dystonia or spasmodic dysphonia, laryngeal dystonia. We need to understand better what is the actual cause of sleep disturbances in patients with dystonia, although we have a number of hypotheses that I outlined earlier. The psychological processes potentially linked to insomnia in dystonia, like attitudes about sleep, dysfunctional beliefs, poor sleep hygiene, preoccupation, should really be considered, and sleep hygiene should be improved. When we do a study on dystonia, we should always include, even as a secondary outcome, sleep quality, and we need to start doing targeted studies that test the efficacy of sleep interventions in dystonia. And this is my last slide. So again, it's pointing once again to what is the ideal clinical model for dystonia, which is that of a multidisciplinary assessment. Now we don't have capacity to do this every 3 months, but ideally people with dystonia should have access to this type of multidisciplinary assessment that incorporates the evaluation of depression, anxiety, fatigue, sleep quality, and pain, at least thoroughly once a year. And we can use self-administered questionnaires and other ways, simple ways of monitoring these symptoms every 3 to 6 months without an increased cost on capacity for our assessment. And these multidisciplinary clinics really should involve ideally at least at long intervals, even other allied health figures, including social workers, a psychiatrist, and physio and OT. But overall, this is where inevitably the field will move towards, and it's a matter of understanding how long it will take us to translate this into clinical reality. Thank you very much. And I'm very happy. This is what I had to present today, so I'm obviously happy to answer questions.
Thank you so much, Dr. Martino. That was an excellent presentation, and certainly DMRF Canada and the patients that we serve, we continue to hear about the connection between the motor symptoms and the non-motor symptoms of dystonia, which is, I think, really why we're trying to focus on topics like sleep and pain, and really understanding the connection between these things. So obviously anything we can continue to do to help bring these things together for the patient community, we'd love to do them. In terms of questions, we have some. So please feel free, to those of you who have not already, to put your question in. And Dr. Martino, if you don't mind, I'll just throw them your way. One question is, what do you think about the occasional use of Gravol for sleep?
So, well, Gravol is quite sedative. All the medications that can be used, as you said, occasionally, and do not have major side effects are acceptable. We have to keep in mind that Gravol in some patients has been found to worsen dystonia, so we have to be careful. I would ideally use more other medications, including the sleep-inducing medication. I'm not saying that benzodiazepines should never be used, but they should be used not in chronic. That's the main difference. So if one is struggling with sleep, taking a medication that has proven to be effective on that individual for sleep once in a while, it's not a big problem, and it's acceptable. I am concerned of addiction and chronic use.
Right. Okay. Thank you. Following the same line of questioning, there's a specific question around the timing to take medication, and forgive me because I think I will be mispronouncing the name of this medication, but the question is, I am taking escitalopram for anxiety.
Escitalopram, probably.
See, you said it so much better than I did. For anxiety at 10 milligrams OD. I was told to take it in the AM. Could it have more benefit to sleep if I took it at bedtime?
No, because it has a very long half-life, and also it doesn't work as a sleep-inducing medication. So it's an antidepressant medication that helps with mood regulation and anxiety regulation, and its mechanism of action is pretty much constant over time. So it's not a medication that helps only in the time window of the few hours after you've taken it. So the important thing is to take it regularly, and it's going to generate effect throughout the 24 hours. So it's better to take it as an AM. It's because sometimes those medications can produce a little disruption in sleep and reduce REM sleep. So AM use is preferable.
Okay. Thank you for that. Another question that's come in is, do you have any evidence to suggest that sleep worsens in dystonia during the hormonal phase of menopause?
That's a good question. We don't have evidence showing that pretty much anything around the perimenopausal period in people with dystonia, in women with dystonia, unfortunately. We don't even know whether dystonia itself gets worse. So the short-term answer is no. Of course, we know that there are emotional dysregulation issues in that period of life, and those can indirectly impact sleep for sure. But I am not aware of any specific study that has looked into this. It's a good question.
Okay, thank you. We have a few questions that have come in regarding melatonin, so I'll ask both of them, and then maybe it will help you sort of structure your response. First question is, what are your thoughts on taking natural medication like melatonin? And then a second question is, if melatonin should only be administered for the short term, what do you suggest for the next step? Is a product like Unisim or any sleep aid okay for the long term?
Okay, well, melatonin, the way melatonin works is the external, so melatonin is produced by our brain. So we have melatonin in our brain. We use external melatonin to basically increase the supply and accelerate and speed up the way it can function and work in our brain. And what it does is retuning, as I said, our sleep wakefulness cyclic activity, tuning it properly to the light darkness cycle. In other words, we would have a more regular time pattern of sleep, and our sleep hygiene will improve. I am definitely pro its use. Melatonin is not I mentioned a 12-week cycle of use of melatonin just because we don't want to suppress too much the brain production of melatonin, which would inevitably happen if we take it externally forever, indefinitely. However, we can do a cycle and then we can do a washout for another 10 to 12 weeks, and then we get another cycle again. So it can be used cyclically, and you can alternate it with a PRN, so as and when use of sleep-inducing medications if sleep induction is the main reason why you are also taking the melatonin. So in that case, benzodiazepines can be used for 2, 3, 4 weeks, as long as they are under medical monitoring and there's a doctor telling you to stop it at some point. So I would alternate, as you're saying, melatonin and sleep-inducing tablets if sleep continues to be an issue. The other thing is that melatonin sometimes sorts out things for a longer period of time, and there's an after effect, beneficial after effect that melatonin can produce, and which can remain visible once you stop taking the melatonin. So it's a case-by-case decision, but you can reuse melatonin if you've had a cycle of it. So it's just, you need a drug holiday in between.
Okay, that's good. Thank you very much. Another question we have is, can levodopa worsen insomnia?
Yeah, well, it's a good point because excessive use of dopamine, excessive use of pro-dopaminergic drugs can, to some degree, have an effect on sleep interruptions, can make the sleep more interrupted. However, I don't think this is an issue for dopa-responsive dystonia, because typically those patients tend to take the last dose towards a few hours before going to sleep, and by that time levodopa has been washed out from the system, because really levodopa lasts for about 4 hours, and then we need to repeat it to take it again to restore the effect. So I don't think levodopa should only be used in people with dopa-responsive dystonias or Parkinson's disease or other Parkinsonisms. So I would not suggest to try levodopa. I don't think that anybody would prescribe it actually, but just for sleep control, because that's not going to be effective and it's probably going to be detrimental.
Okay, thank you very much. We have time for just a few more questions. One question was, this is related to one of the statistics you spoke about in your study. And the question is, did you include people whose contractions worsen when they lie down in the study of how dystonic movements affect sleep?
Sorry, can you repeat it? Because
yeah, for sure.
I'm not sure exactly which piece of data this refers to, but
I think it might be the Dystonia Coalition cross-section, okay. I think.
Okay.
The question was, did you include people whose contractions worsen when they lie down in the study of how dystonic movements affect sleep? And I would imagine so, but
no, actually not that much, because when we assess the severity of dystonia, we don't specify the severity of dystonia when lying in bed as opposed to during the day. No, that's a good point. That's definitely a good point. That study that I mentioned was not a sleep study. That study was just a study that shows how many different types of medications people with dystonia take. And it was helping me to make the point that those medications could affect sleep. But that particular study did not look into that. And in general, we don't evaluate, when we do a sleep study, we don't really evaluate whether dystonia worsens when lying supine. But some patients do report that. I would say the minority of patients, though, they do report that. Some people with more severe dystonia, they will obviously struggle more, as I said, or have more pain related to it, which will impair sleep. But that's a good confounding, I think, and it's and for future studies we should include that particular clinical feature in our analysis. That's a good point. Thanks.
It's a good point. Yeah. Okay. Thank you, Dr. Martino. I'll ask one more question. I see there's a few that we're not going to get to, and we'll do our best to chat with Dr. Martino and the resources on our website
Sure.
to send out some additional points just to make sure that no questions are left unanswered. But to finish off, I'll leave you with one last question, Dr. Martino, which is, do people with dystonia physically require more sleep? And if so, how many hours a night is suggested?
No, they don't. They don't necessarily require more sleep than others. They happen sometimes not to sleep well enough. So they end up requiring more sleep because they have had poor sleep before, and so they can be constantly in defect of sleep. This is why sleep hygiene and managing sleep problems is very important. But not as a baseline, there's no particular need to sleep better. What is important is that I mentioned the young kids with dystonia who can have severe worsening of dystonia that eventually can escalate into a dystonic storm or status dystonicus. Now, those individuals will start sleeping badly, and then as they drift towards this severe worsening of the dystonia. So in those people, there's a clear connection between how well they sleep and how badly their dystonia is. But overall, dystonia patients should sleep as well, need sleep just as anybody else. Okay.
Wonderful. Well, this brings us to the end of the hour. So once again, huge thanks to Dr. Martino for the wonderful, informative presentation, and thanks to all of you for tuning in and for providing us with such thoughtful questions. And I just wanted to take a moment to thank Ipsen Biopharmaceuticals for their very generous support of the Living Well webinar series. I also wanted to remind you that Dr. Martino's colleague, Dr. Bruno, will be hosting a session like this on dystonia and pain, and that session will be coming up in July. So you can find more details on that webinar and any others at www.dystoniacanada.org. So with that, I thank you all for tuning in, and I wish you a wonderful day. Thanks again.
Thank you very much.
Thank you. Bye-bye.
Bye-bye.